Assalamu alaikum wa rahmatullah. So after we finished the disorders of the shoulder, now we will be moving to the elbow and wrist. So as you all know, the elbow is composed of the distal humerus with the proximal forearm, which is the radius and the ulna, as you can see here. The radius is articulating with the capitulum, and the ulna is articulating with the trochlea, which is the medial, and the radius is in the lateral aspect. These are like the most important ligaments which are stabilizing the elbow. The elbow is a hinged joint moving in one axis, flexion, extension only. So we have very important ligaments like the ulnar collateral ligaments here, which is preventing the valgus stress for the elbow, the ulnar collateral ligament, and the radial collateral ligament, or medial collateral ligament and lateral collateral ligament. We have here the annular ligament, which is going around the radial head. As you all know, the radial head is doing the pronation and supination. That's why the annular ligament is going around the radial head. Now for the elbow, there is a very important angle we have to know, which is called the carrying angle. So what's the carrying angle? As simple as that, it's the angle between the axis of the humerus with the axis of the forearm. So if we want to draw the axis of the humerus, it will be like this, and the forearm, it will be like this. So you see that the angle is like less than 5 degrees. The normal angle in here, okay, and this is called the high angle. So if the hand or the forearm is going medially, as in the first situation, it's called cubitus varus. So cubitus is elbow, varus is medial, so cubitus varus. Normally between 5 and 15 degrees, which is the normal carrying angle. In females, it's more than males. And if you go after 15 degrees, it's gonna be the cubitus valgus. So it will be going more than 15 degrees to the lateral side. Okay, good. So elbow deformities, cubitus varus. So it's less than 5 degrees. It's called gun-stock deformity, gun-stock deformity. So cubitus varus usually happens after a malunion. Malunion, it's united fracture, but in a wrong way, for supracondylar fracture, which is the most common fracture in the pediatric age group. Okay, so malunion will cause you cubitus varus, which is gun-stock deformity. On the other hand, if the forearm is going lateral, it's going to be cubitus valgus. Cubitus valgus more than 15 degrees because of non-union of a fracture of the lateral condyle. So what will happen if a lateral condyle having a fracture in the pediatric age group? You all know now that there is something called the epiphyseal plate, which is the growing area. So when they have damage to the lateral aspect, it will stop growing, and the medial aspect will keep on growing. So what's going to happen? Lateral is not growing, medial is growing. It's going to be pushed to the lateral aspect. So it's going to cause them cubitus valgus. What's the problem in here? Because the elbow is going toward the lateral aspect outward, valgus, the ulnar nerve is going in the medial side. So it's going to be stretched. The more and more the medial condyle is growing, so it's going to be moving outward. So the ulnar nerve will be stretched, and sometimes they might present with ulnar nerve palsy, ulnar nerve tardy palsy. So these patients, either we do transposition of the ulnar nerve, we move the ulnar nerve, so we decrease the tension on it, and sometimes we can do osteotomies for that. As you can see in the upper picture, the red one, this is a typical gun-stock deformity. Usually the gun-stock deformity, you can see it only when the patient is extending the elbow. When they do flexion, you cannot see the deformity, okay? Because the carrying angle is between the arm and the forearm. So when they are flexed, you cannot see the angle. Another picture here, you can see cubitus valgus. So this is cubitus varus, the gun-stock deformity. Cubitus valgus, you can see the carrying angle is very severe, and this is the X-ray. And you can see here that it might affect the ulnar nerve. Pulled elbow, very common, very common. The pulled elbow is very common, which is downward dislocation of the radial head. As I showed you, there is the annular ligament around the radial head. Usually in pediatric age group below the age of 6, the mother, one of the people wants to hold the child from their pronated arm. So when they pull the arm, the radial head dislocates. So it's called pulled elbow. Sometimes we do X-rays to make sure that there is no fracture, because usually they don't present with swelling and signs of fracture. So if there is signs of fracture, swelling, redness, hotness, so whatever, you should do X-ray. Otherwise, you do reduction. How do we do reduction? We do hypersupination, flexion, and then we relocate the radial head with our thumb. Subluxation of the radial head associated with bone dysplasia usually, in which the ulna is shortened. Ulna is shortened. So shortened ulna means the radial head is dislocated. And as you remember from the forearm fractures, whenever you have an ulnar fracture like Montijo with radial head dislocation, you have to reduce the ulna first. So when you reduce the ulna, the radial head will reduce spontaneously most of the times. If there is unreduced dislocation of the radial head, usually with Montijo, as I told you, it will be causing permanent. Most of the time, we have to go for open reduction and we have to fix them with K-wires. Okay, osteochondritis dissecans. We talked about this disease before. Another time in here, usually it's happening between the articulation between the radial head and the capitellum. And usually the capitellum is the most important part because of repetitive trauma. As you can see here, this is the radial head, which is articulating with the capitellum. And this is the most important or the most common site in the elbow that might have osteochondritis dissecans. The patient will be presenting to you with effusion, tenderness, limitation, and range of motion. And if there is a chip inside, the fracture of the capitellum is going inside the joint, there will be locking sometimes. There will be decreased range of motion. Why it is intermittent? Because this piece is moving inside the synovial joint. If it's inside, it's blocking the range of motion. The patient will present with intermittent locking. Otherwise, if it's outside or it's away from the joint, it's inside the capsule but outside the articulation, it won't cause locking. X-ray is important to see the fragment. CT, MRI are more useful for sure. If the patient is asymptomatic, conservative. If symptomatic, we have to remove this piece, either open or by laparoscope with the scope inside the joint, and we remove it. Loose bodies, the most common cause is osteochondritis dissecans. If it's a loose body, not from this cause, symptomatic, asymptomatic, asymptomatic, observation. Symptomatic, you have to remove it. As simple as that. So you can see here some loose bodies. These loose bodies may cause limitation in flexion, because when the patient is trying to flex, okay, the ulna will be hitting these osteophytes or loose bodies. So we have to remove them. Tuberculosis is just the same as the proximal humerus that we talked about. Usually the most important signs and symptoms as any other infection disease, which is redness, hotness, fever, and so whatever, but muscle wasting is important in tuberculosis, and you can see in X-ray that there is increased in joint space. What to do? Listen carefully. Any joint which is swollen, single joint which is swollen and has the signs of infection, which is redness, swelling, hotness, decreased range of motion, and if it's in the lower limb, unable to be raised, you have to tap this joint. You have to aspirate. We have to get fluids before giving antibiotics. Never give antibiotics for a patient without diagnose him, please. Never diagnose, never give patient antibiotics before diagnosing him with a disease. So we do withdrawal of these fluids, okay? We do tapping. And we send these fluids to the laboratory and we ask for count, okay, very important. We ask for crystals, we ask for gram stain, okay, and sometimes we ask for sugar and protein. So these tests are very important to have a differential diagnosis. Treatment, anti-tuberculosis drugs, surgical debridement if needed. Sometimes we go for arthrodesis or arthroplasty, depending on the stiffness, on the patient, the age, and so whatever. Same thing, rheumatoid arthritis. Rheumatoid arthritis, usually the problem I told you with the synovial, as we already mentioned in the humerus. So at X-ray, you will see chronic inflammatory arthritis, widening of the trochlear notch. So these are the signs, and sometimes you can see nodules, which is specific for rheumatoid arthritis. What's the treatment? Rest, corticosteroids. We are trying to rest the joint. Sometimes they don't really get better, so we have to go and do synovectomy. So we remove the synovium, which is the source of inflammation in this disease, and patients will get better. This is a picture of an arthritic joint. As you can see that it's the bone erodes, the capsule is inflamed. Osteoarthritis. In the elbow, it's not really common to see osteoarthritis, but if you see like osteoarthritis, think about underlying cause. Either another pathology, fracture, gout, pseudogout, and so whatever. So you have to do good examination and x-rays. And x-rays, you can see the 5 important things: decreased joint space, osteophytes, subchondral sclerosis, and cyst, and so whatever. The same as like osteoarthritis we talked about in the lecture. Treatment. What to do for osteoarthritis? We already talked in special lecture about osteoarthritis, which is non-steroidal anti-inflammatory drugs, debridement sometimes. If there is osteophytes, you have to remove it. And you may see ulnar neuritis. That's why we have to transpose the ulnar nerve. The last option is joint replacement. Charcot disease. Do you remember patients with diabetes mellitus in the lower limb? It's the same in here. So they have a neuropathy, no pain, and we have flail elbow. Ligamentous problem, bony problem, X-ray is important, and sometimes treatment you have to splint or arthrodesis. Gout and pseudogout, well, usually they present with olecranon bursa. And as I told you, in every prominence bone, we have a bursa. What's a bursa? It's a fluids inside a sac, which will decrease the pressure in the bone, and it will decrease the friction. So usually you will find either uric acid for gout, and you should give them high and non-steroidal anti-inflammatory drugs, or pseudogout, calcium pyrophosphate. Stiffness of the elbow. Do you remember that I told you the most bad, the worst complication you might have for any joint is stiffness? So stiffness is really very bad. So because of congenital abnormalities, synostosis. What is synostosis? Radius and ulna, both of them, they have membrane between them. Sometimes they might have, after injury or idiopathic, that bone is having bridges between these two bones, between the radius and the ulna. So they will be one bone. So this is called synostosis. That's why the patient will have blockage in pronation and supination. They cannot pronate and supinate because the radius is going over the ulna normally. But if there is synostosis, no radius is going over ulna. Infections, osteoarthritis, and trauma. Post-traumatic stiffness. If someone has a stiff elbow, you might think, what's the cause? So we have 2 main like subgroups. It's either extrinsic or intrinsic. So if it's extrinsic, you will think about soft tissue contractures, hypertrophic bone formation, or inside the joint. If it's inside the joint, intra-articular adhesions or articular incongruity. Articular incongruity because of intra-articular fracture, but the problem, they did not reduce it at the principles. Anatomical reduction, absolute stability. Don't forget these principles. The most effective treatment is prevention. And serial splintage for sure. Sometimes after 1 year of trial physiotherapy, we fail, we might go into surgery. We go, for example, we release the tissues that's causing stiffness, we go inside the joint, we remove the fibrous tissue, and so on. Overuse, repetitive strain syndromes, they are very important, very common. The most important one of them is the tennis elbow. So what's the tennis elbow? Tennis players usually they have, when they are playing, they have a shots which is called either forehand like this or backhand. So when they are playing the backhand, they are doing wrist extension. And when they are doing extension, you can see that they are moving the extensor compartment. As you all know, the extensors are going to the lateral epicondyle, to the common extensor muscle. So the common extensors are going and they are attached to the lateral epicondyle of the humerus. What's epicondyle? I know condyles, medial and lateral. So medial and lateral condyles are the bony part. The epicondyle where the muscles are attached to the bone. Okay, so it's the epicondyle. So the lateral epicondyle, when they are doing extension and extension and extension, there will be micro ruptures in the common extensor on the lateral epicondyle. So they will start to have pain because it's closed compartment. The pressure will increase, inflammatory process, tissues, interleukin, cytokines, they will be having pain and pain. So they cannot do back hands anymore. So the patient will be presenting to you with pain and they will have tenderness in here. Sometimes they might get redness and hotness there because of the inflammatory process. So what's the treatment? The most important thing is to rest. They have to rest. Cold compressors like ice is very important. Non-steroidal anti-inflammatory drugs 2 to 3 weeks, and they return after physiotherapy to the sports. If it stays, sometimes we can give there an injection of corticosteroids, which might really help. The problem with the patient who are getting chronic tennis elbow and it's very bad for them because they stopped doing their sports, we can go and do surgery and we do release of these common extensors. So this is for the tennis players. On the other hand, we have the golfer players. So in the golf, you know, they hold the golf and they hit it. So they are doing the other way around. Tennis is doing extension. Golf is doing flexion. So flexion of the wrist is going to the flexor compartment. So here is the extensor, common extensor. Here are the common flexors. The common flexors are holding to the medial epicondyle. Lateral epicondyle, tennis. Medial epicondyle, golfers. The same pathology, same treatment, so the same sequence. So this is the tennis and the golfer elbow. This is pain on the lateral aspect of the lateral epicondyle, which will elect pain. So one of the tests is very important. You ask the patient to extend the wrist against resistance. They will have pain in the lateral epicondyle and the middle finger. So we are extending the metacarpophalangeal joints. Golfer elbow is the same. Baseball pitcher's elbow. So what's happening with the baseball, as you can see that this baseball player is having fully extended elbow and he's pushing or doing rotation. So they have damage to the soft tissue and bone attachment around the elbow. So they have hypertrophy and they might get loose body formation inside the joint. Very common, student's elbow. Most of the time, medical students or the nursing students, the people who are studying many hours, usually they sit and write on this aspect. So they put their weight on the elbow and they start writing. So this elbow is having pressure and pressure and pressure. And as I told you, there is something called here the bursa. The bursa, which is a fluid-filled sac, which decrease the pressure and the friction. So this might get inflamed and it will get swollen and swollen and it will become a big balloon. So this is the first type. The second type, which is the non-traumatic, which comes with gout or rheumatic arthritis, rheumatoid arthritis. As you can see, this patient is having bilateral bursitis. So what to do for these patients? We start with conservative, cold compress and painkillers, rest, and we tell them to put their elbow on a pillow, so we decrease the pressure. The second step is we go and aspirate and we give sometimes injection corticosteroids. If this did not work, we go for surgical excision. Avulsion of the distal biceps tendon, avulsion of the distal biceps tendon. You remember the proximal biceps tendon and it will cause you Popeye sign for the patient. Usually if they are old, we don't go and do surgery. If they're young, we do surgery. Here is the same. Most of the time we don't do surgery and we can confirm the diagnosis by MRI. We can go by arthroscopy and remove the loose body. We do irrigation, trimming, and sometimes synovectomy, and we can do repair of the tendon. Now we will go to the rest. The rest in children or the pediatric age, we have something called carpal fusion. And if you just look at this X-ray, you can see that the scaphoid and lunate here are like one bone. This is called coalition. So what's coalition? Is fusion of 2 bones. We have very common in the foot and ankle also. We have coalition. So what's coalition? Is 2 bones are getting fused. So there is no more movement. No more movement means abnormal biomechanics, means pain. So the most Like sensitive test, CT scan. We do CT scan and we can diagnose all of these carpal syndromes. A lot of X-rays here showing carpal coalition. Okay, radial club hand or radial longitudinal deficiency is a problem in the radius usually, or sometimes it might be completely absent. There is no radius, there is no radial bone. So sometimes it might affect the thumb, scaphoid, or trapezium. So what's the treatment? Usually, if it's simple, gentle manipulation, sometimes we go for surgical treatment to improve the appearance from 6 to 9 months. Usually, this is the window of surgery. And then we go and do correction and KORs. X-ray and picture showing the club hand. So there is no radius, only ulna. Another X-ray. In bilateral cases, elbow stiffness is contraindication to surgical correction. This is very important. If you have a patient with a club hand and elbow stiffness, it is contraindicated to go for surgery. Why? Because they depend on radial deviation, on this radial deviation, because there is no radius, they are doing radial deviation, okay? Because they depend only on radial deviation to reach the mouth. So if they have elbow stiffness, it's contraindicated to do correction for the hand. So if you now correct the hand, they cannot reach their mouth. That's why if you have a patient with a stiff elbow and a club hand, just leave it because they can reach their mouth. They can eat. Another time, orthopedics is for function, not cosmesis. Ulnar longitudinal deficiency, it's like radius, not this time, the ulna is not here. Treatment, early stages, stretching and splintage, if it's marked deformity, excision of ulnar angle, and osteotomy of the radius. Madelung's deformity is lower radius, but it's curved forward, carrying with it the carpus of the hand. So if you can see the X-ray, you can see this is the distal radius, this is going volary or forward, and the carpal bones are going with it. Okay, if deformity is severe, the lower end of the ulna may be excised, okay, may combine with osteotomy of the radius. So it's osteotomy, we are trying to return to its normal function. It's rare, this disease. Arthrogryposis multiplex congenita, it's rare, it's rare. It's joint contractures all over the body. As you can see in the picture, this patient had myopathy and neuropathy, a lot of causes. Limb is atrophic because there is no movement. The muscle is atrophic too. The elbow is extended and the wrist is flexed, as you can see in the picture. Ulna deviated and thumb adducted, fingers flexed. So it's complex. It's part of congenital diseases. So treatment, it's difficult. Usually treatment is difficult. We do sometimes serial splintage to make the deformity look better and for better function. Sometimes we go and do capsulotomies so we can release the joints to make them move. Severe joint deformity, sometimes they require soft tissue release. Tendon transfers, we can do tenotomies and so whatever. Some acquired deformity, if you have physical injury again and again and again, one part of the physis will be growing normally, the other part is not growing, so there will be deviation depending on the injury. Rheumatoid deformity, radial deviation, and you all know this picture you can see in here, it's pathognomic for rheumatoid deformity. If someone is having wrist drop, so there is a problem with the radial nerve. As you know, Saturday nerve palsy. Why it's called Saturday nerve palsy? Because people usually Saturday night palsy. So what's happening that patients usually Saturdays they go and they do drinking, and when they are overwhelmed and they're having hangovers, they sleep on the first desk they see. So it's having pressure on the radial nerve. So the other day they wake up, they cannot extend their wrist. So it's called Saturday night palsy, which is radial nerve palsy. It will recover alone with time. Okay, articulations of the wrist. You all know that the radio-ulnar joint and the radius are the ulnar articulating with the proximal carpal row. Proximal carpal row. This is the proximal row, distal row, and this is called the mid-carpal joint. Chronic carpal instability. This is a very wide, very common, very complex subject. But usually the rest is stabilized by a lot of ligaments, very complex ligaments in the hand between all of the carpal bones. Post-trauma, sometimes you might have injuries for these ligaments, which is sometimes really hard to diagnose. That's why history is very important. Physical examination of each point is important, and X-rays with MRIs. Okay. Instability of the distal radio-ulnar joint. You remember this from the upper limb fractures. We talked about the piano key sign when you are putting pressure on the ulna and the ulna is going down, and when you remove the pressure, the ulna goes up. So it's like a piano key, which is giving you an instability in the distal radio-ulnar joint. Radiocarpal and intercarpal joint, they will cause usually wrist pain. The patient will present with wrist pain, especially if he's a weightlifter, if they depend on their hand a lot on their work, a lot of mechanics and so on, they will have pain and pain and pain. A lot of types, I'm not gonna go through them because they are very complex, and as medical student, you don't have to know all of them, but you know DC and VC, which is dorsal intercalated segment instability, or volar and volar intercalated segment stability, very complex things. Mid-carpal instability and radiocarpal instability. So these are the common causes for radiocarpal and intercarpal joint instability. Again and again, pain, pain, pain. The patient can't move his wrist. He's going to present with weakness. Tenderness usually, and very important test upper limb surgeons or hand surgeons, they love to do is grip strength. So they have a device and they let the patient grip on it, and they assess the grip bilaterally to compare. Okay, Watson test is scapholunate incompetence by putting thumb pressure, and you will hear painful clunk. Luno-triquetral palutment. Usually I told you we examine each carpal ball alone. So we hold the lunate, and with the other hand we are moving the scaphoid. So we are testing the scapholunate joint, or the luno-triquetral palutment. It's the same. So you're holding one carpal bone, moving the other one, trying to induce pain. For example, this X-ray, you can see that the scaphoid is very far from the lunate. That's called Terry Thomas sign, because Terry Thomas, who diagnosed this case for the first time, his teeth, they had a gap. That's why it's called Terry Thomas sign. Tuberculosis, again and again, it's the same. It's just the same. Tuberculosis, rheumatoid arthritis are really the same in all the joints. So you have to follow the steps step by step. Okay, wrist deformities should be corrected before hand deformity. So wrist should be diagnosed and treated before hand. Osteoarthritis, the common type is after scaphoid fracture, and then you will get osteoarthritis. You might get Kienbock disease, which is, I told you before, which is osteonecrosis or avascular necrosis of the lunate. And I showed you the grades before in one of the lecture. Carpal osteoarthritis is very common in the postmenopausal woman. X-ray for sure because it's osteoarthritis, and the treatment depends on the stage and the pain of the patient. Kienbock disease, we already talked about this in the previous lecture, which is avascular necrosis of the lunate, and we have the stages, and I showed you the stages with the X-ray in the upper limb trauma. And you can see that the lunate is poorly supplied, and it has a lot of articular surface. That's why it's have a lot of AVN. Ganglion cyst, very important, very common. Most of the patients, they present to the clinic and they do, oh, doctor, I have a bump in here, like a small nodule, and it's irritating and painful. What's the story of the ganglion cyst? In the past, because of a lot of function and movement and working on the hand, there will be inflammation in the joint and there will be increased pressure. That's why the synovium, it will herniate and it will give you a bump, which is the ganglion cyst. They used to bring a book and hit this bump or this swelling with a book, and it will disappear. It will cause severe pain for sure. It will rupture. All the fluids inside, which is the synovial fluid, will go out, and the patient will be okay after that. The problem is the recurrence rate is very high. What if we try to put an injection inside and aspirate the fluids? Another time it's gonna get back again. What if we go there and we excise this ganglion cyst, especially from the scapholunate joint, which is the most common, it might come back. That's why before you go in a ganglion cyst and remove it, you should tell your patient that it might recur, whatever we do. Either we do aspiration, either we do excision, so whatever, it might get back. So usually it's conservative treatments, splintage, painkillers, ice until it resolves. And if the patient keep on nagging, he wants to remove it, we can remove it for him. But the recurrence rate is 30%. This is the picture of the ganglion cyst. Tenosynovitis, which is inflammation of the tendon. Tenosynovitis, itis, inflammation. Teno, which is tendon, synovitis, so it's inflammation of the tendons. Pain. This is how they present. So we give them non-steroidal anti-inflammatory drugs, and we splinting, we do resting, but we have to make sure it's not pyogenic. We have to make sure it's not an infection. If it's inflammation, okay, we treat it. If it's infection, this you have to keep in mind. It's very important. So tenosynovitis, extensor retinaculum usually happen. Overuse of these muscles will cause inflammation. It will give you tenosynovitis. The most common compartment, you know that there is 6 extensor compartments or dorsal compartments of the hand. The first compartment is very important for the extensors, which is called de Quervain disease. It's very important to know about. So de Quervain disease, as you know, these two tendons, the abductor pollicis longus, extensor pollicis brevis, they are going in the first compartment, which is just above the radial styloid. So how do we do examination for these patients? History, physical examination, investigations. In the examination, you will have tenderness on the radial styloid. And there is a test which is specific for de Quervain, which is called Finkelstein test. So we put the thumb inside the hand and they do grip. Then we hold the hand and we do ulnar deviation. So we are stretching the first compartment. So there will be election of the pain and we will elect the pain. So tenderness, Finkelstein test, most of the time it will be pathognomic sign for de Quervain disease. We can go conservative, splinting, and non-steroidals. If it didn't work, we can go for injection, corticosteroids. If it didn't work, we go for surgery. And that was all for the elbow and wrist deformity. Thank you.